Hello, my name is Donny Firman. I'm a chairman of Indonesia Society of Interventional Cardiology. So on behalf of my society, I would like to say thank you for TCTAP 2022 committee to let us run our scientific program. The theme of our program will be a STEMI or PPCI. So without further ado, I would like to introduce my co-moderator, my friends, Dr. Paul Ong from Singapore. Paul will introduce all the faculties and also introduce our first speakers. Please, Paul.
Thank you very much, Donny, and thank you for TCTAP and Isic for a very kind invitation to moderate this session. I'm actually very pleased to have all our good friends joining us here today. Dr. Ashri Ranga, Dr. Fauzi, and Dr. Youssef are going to be our esteemed panelists. Without further ado, maybe we will introduce our first lecturer, Dr. Ismail Fari from Indonesia. He's going to talk to us about STEMI in Indonesia, the social, economics, and demographic challenges. Over to you, Ismail.
Thank you, Chairman and moderators, and all to the TCTAP for having me here. My lecture topic today is STEMI in Indonesia, social, economic, and demographic challenges. I have no disclosure. As we know that Indonesia is a country consists of more than 11,000 islands with multiple ethnic and language, with a population more than 273 million, and 60% population are centralized in Java Island. Our GDP rank is number 16 in the world and put our country in a middle income country. We are facing on transition from communicable disease to non-communicable disease problem. The geographic and demographic made a challenge in our health system. There's still disparity infrastructure development between Java and out of Java Island. Big city were better infrastructure facilities, while in rural and remote area are still facing on access for transportation and lack of healthcare provider and facilities. And our GDP per capita is around 3,869 USD per capita per year. So this challenge needs to be handled by providing a national health insurance program, increasing our gross domestic product, human resource development, improve of healthcare facilities and infrastructure, and also public education. In December 2021, the National Insurance Program coverage is already around more than 86% of all population, which made it the biggest insurance program in the world, with low insurance fee, about 3 until 10 USD per month per person. And since 2014, the Universal Health Program reported that cardiovascular disease as the top of the catastrophic disease, which costs more than 134 billion US dollar per year for the reimbursement, while the STEMI case estimation is more than 296,000 per year, and the STEMI direct cost about 3,400 USD per cases. Our national health coverage reimbursement depend on the case severity and hospital level. And patient underwent primary PCI in Type B hospital, we can see that the reimbursement is around to 0.5 thousand US dollar until 7.3 thousand US dollar. And for patient who got only prebiotic is around $250 until 1,600 US dollar. As we can see, this the spread of a cath lab in Indonesia. There are 292 cath lab over 250 hospital, and we only have about 209 cardiologists in Indonesia. Now we talk about the STEMI. The ACS registry was first started in West Jakarta and saw low perfusion rate, and more than 50% are late presenter. Based on it, we try to fix the problem by increasing the awareness with standardized localized protocol and launch iSTEMI program conducted by ACC and Isic Working Group of Indonesian Heart Association. The iSTEMI vision is to refuse all STEMI patients with our mission. And the iSTEMI program was expanded to 11 centers across Indonesia. Based on the ACS STEMI patient characteristic, we can see that more than 80% of patients who got STEMI now were covered by our national health insurance. And in the STEMI case, based on this registry, we can see that 48.8% are STEMI, and then 65% all the STEMI underwent reperfusion, and 70% will perform primary PCI, and 29% using fibrinolytics. And overall reperfusion strategy is primary PCI around 65%, and the patient with presenting below 12-hour onset, what we call it eligible patient, reperfusion rate is more than 81%. I think this is a good number. And overall reperfusion strategies, the primary PCI is about 45%, and lytics is 18%. If we can see in the right chart, in National Center Harapan Kita, there is 72% STEMI patient underwent primary PCI, while in Type B hospital, there's around 40%. And we can see that in the Type B hospital, the primary PCI and the lytic have the same proportion, about 30%, but we can see that the fibrinolytic successful rate in Type B hospital is more than 70%. And here is the conservative strategy rationale why that people doesn't get any reperfusion, because the onset is more than 12 hours, also cost, and also the refusal from the patient or her family. And based on healthcare facility performance, we can see that the onset of to first medical contact is around 115 minutes median. Transport time is 165 minutes, and door to device is about 90 minutes, and door to needle time is about 60 minutes, and the ischemic time is around 405 minutes. But if we see based on the hospital type, we can see that the National Harapan Kita is better in hospital performance, is better in door to device and door to needle time. But overall, we can see that the ischemic time is better in Type B hospital, because this is the nearest facility that that people can get early revascularization. And the outcome from this registry, we can see that among patients with early presenter and who has a reperfusion, it is have a better outcome rather than without any reperfusion, with mortality rate around 9 to 10%. And in early pandemic situation, we have decreased number of STMI cases and primary PCI patient, and we also have a longer door to bound time, as we published last year in Frontier Cardiovascular Medicines. So to close my lecture, my conclusion that the national health insurance provide all citizens to have affordable and equal healthcare services, and then central government need to reduce the interregional disparity in terms of resources, service, and health outcome. Increase reperfusion rate by developing more regional network, breakthrough in reimbursement policy, increase community awareness and availability of more simple and effective fibrinolysis method, and also improve door-to-balloon and door-to-needle time in district hospital. And the last, that we have to integrate disaster and emergency management need to be improved to have a sustained healthcare service against future pandemic. Thank you very much for your kind attention.
Well, thank you, Dr. Ismir, for really informative information. So we now have some information what happened in Indonesia regarding the patient with STEMI. So due to the limited of time, I would like to jump to our first case actually. So I would like to introduce my colleague, Dr. Andika Sitepu. He is working in Adamalik Hospital in Medan, North Sumatra. Dr. Andika, in his presentation, will talk about the spike helmet sign related to in-hospital death in patient with STEMI, a case series. Please, Andika.
Yeah, thank you, moderators and all panelists. Good afternoon. My name is Andika Sitepu from Medan, Indonesia. I would like to present my case, the title, The Spike Helmet Sign Related to In-Hospital Death in Patient with STEMI, case series. I have no conflict of interest. Spike helmet signs resembling to German military helmet is usually seen in critical ill patients and associated with high risk in hospital death, characterized by ST segment elevation, where the upward shift of the baseline starts before the onset of the KRS complex, doom, and spike appearance. The first case, an 80-year-old man with cardiogenic shock preceded by typically infarcted chest pain for 12 hours was admitted to our hospital. He was agitated with low blood pressure and tachycardia. The ECG showed elevated ST segment at V2 until V6, 1 AVL, with spike helmet sign in V5 until V6. Cardiac enzymes show elevated troponin T and CKMB. Previously, he was given loading of aspirin, clopidogrel, and unfractionated heparin from another hospital. He was also put on vasopressor therapy with norepinephrine due to hypotensive blood pressure. He was diagnosed with acute anterior extensive STEMI, KLIP4, and proceeded to primary PCI. This is the ECG of this patient. We can see ST elevation from V2 until V6, 1 AVL. This is the zoom in of the ECG. We can see very clear spike helmet sign in V5 and V6. Coronary angiogram show that RCA with mild to moderate stenosis. From left coronary arteries, severe stenosis at distal left main, and critical stenosis at mid LAD, slow flow, TIMI2 until 3 with residual thrombus after the stenosis. Yeah, then we continue with predilatation with 2.0 semi-compliance balloon and 3.0 scoring NC balloon from mid LAD to mid left main. And then we put one long stent, DS 3.0 times 36 from proximal left main to mid LAD, and then inflate until 12 ATM, and this is the result. After deploy stent, we continue with POT left main with 3.5 times 12 NC balloon, 18 ATM. And this is the final result. We can see that good result with TIMI flow 3. This is from caudal view and this is from cranial view. Yeah, follow-up for this patient. Unfortunately, this patient was in refractory cardiac shock and died in same day to primary PCI, about 6 hours after primary PCI. Case 2, a 52-year-old man presented with acute lung edema following typically infarcted chest pain within 5 hours before admission to our hospital. He was alert with normal blood pressure and tachycardia. His ECG saw elevated ST segment in inferior leads, included spike helmet sign. Cardiac markers, CKMB and troponin T were extremely high. Chest X-ray saw pulmonary edema. He was given loading of aspirin, clopidogrel, and unvaccinated heparin from previous hospital. And he was diagnosed with inferior STEMI, KLIP3, and proceeded to primary PCI. Yeah, this is the ECG of this patient, sinus tachycardia with ST elevation 2, 3, and IVF. And this is the zoom in of the ECG. We can see spike helmet sign in lead 2, 3, and IVF. Chest X-ray show that this patient with cardiomegaly and pulmonary edema. Yeah, from coronary angiogram, short left main with CTO at ostial LAD, circumflex moderate stenosis at mid and distal part. Yeah, this is the RCA, big RCA, dominant RCA with subtotal occlusion at distal and slow flow with TIMI flow 2. And we can also see the collateral from the RCA to the septal and LAD. From this view, we can also see the critical stenosis at the proximal part of RCA. We continue with predilatation with 2.0 and 2.5 semi-compliance balloon, and then continue with stenting. We put one stent. The first stent, DES 3.0 over 30 millimeter, 11 ATM from distal RCA to proximal PLV. And then we continue, put the second DES 4.0 times 23, 11 ATM at the proximal part of RCA. And this is the final result after two stent implantation with good result and TIMI flow. Yeah. Unfortunately, this patient also died in the third day after primary PCI due to respiratory failure. Conclusion, these cases show us that spike helmet sign is a predictor of grave prognosis in patients with acute microbial infarction. These cases also show us that even after PCI procedures, patients in acute microbial infarction with spike helmet sign are still in high risk of mortality. The presence of spike helmet sign perhaps should alert us more about the possible MACE event after revascularization. Thus, early mechanical circulatory support may be considered in these patients.
Dr. Andika, congratulations. I must admit, this is my first time to hear the new term from you, the helmet sign. So I would like to invite maybe Dr. Asri Ranga. So what about any opinion, Asri, regarding the term itself and also whether it's related to the bad prognosis, or you have other thought?
Hi, I'm Donnie. I'm also learning for the first time about spike helmet sign. It's very hard to see. The second ECG looked a bit more like what you mentioned. It's very interesting to describe this. I think it's white RS complex, you know, and looking at that, looks like especially the second patient already have extensive disease. I'm also perplexed because before this, the indicators of severe, STEMI is usually the ST segment elevation height. It's actually a score, how high the ST segment is to, tombstone and things like that. But this is the shape of it, so it's interesting. And both of them quite bad. The first one was a cardiogenic shock. Whether intra-aortic balloon pump would have helped, I'm not sure. It's already 80 years old, and you did a fantastic job looking at the PCI itself. And the second one, the LED is occluded, maybe the EF is down, and the RC is so diffusely diseased. So whether I think more needs to be looked into this, whether it's a predictor of severe disease and bad mortality. I think we have to do more research into this. Thank you.
All right, thank you, Ashri. So yeah, I think both of the cases is pretty bad. I mean, came with the cardiogenic shock. So maybe MCS early as possible will be the way to answer. So Fauzi, any other thought?
Yeah, I think we should thinking with whether it is the cause is because of the complicated case or because of the late presentations and or because of the procedure itself. In the first case, it is actually is not really a complex because it is looks a disease at the mid part. I don't know exactly, because this is the view that we look at the view. It is whether it is involving to the left main or not, and then when it is involving the left main, whether it is should be stand with the 3.0 stand and part with the 3.5, or whether we need a larger balloon or larger stand. That's my take. And then the cause is the cause of the death of the patient is due to the problem that's already happened, whether there is a mechanical complication and other things, or because of the other one. That's my take. And the second one is already it's already very distress respiratory distress, and then I think it is a very difficult one. In terms of the lesion, is not quite complex. That's what my take. Yeah.
All right, thanks. Okay, I will hand over to Paul to introduce maybe the second speaker. Please, Paul.
Thanks. It's a lovely case. And actually, as always, joining these sessions, you learn a lot yourself as well. So I would like to introduce our next lecturer, who is going to be Andy Haryanto from Bandung, Indonesia. He's going to share with us a case about the GI bleeding after left main stenting in primary PCI. So over to you, Andy.
Okay, thank you, Dr. Paul. So let me share my slide first. Okay, thank you. And thank you for the TCTAP for this esteemed invitation. So I will share a case to you all about the gastrointestinal bleeding after left main stenting in primary PCI. So I have no disclosure. So for the case illustration, this is a 30-year-old male. So he came to our hospital with a typical angina 7 hours prior to admission. The only risk factor that he have is smoking. And this is the ECG. Yeah, we can already see the STEMI in this ECG. And for the lab work, he have an elevated cardiac biomarker, normal hematology, normal kidney and liver function. So with all this data, we decide that we should do a primary PCI. So we give the preload of aspirin and clopidogrel as per usual doses for primary PCI. So this is the primary PCI. The RCA is quite good. And this is the left coronary artery. As we can see a critical stenosis in the proximal of the LAD. So we decided to perform the PCI up to the LAD. So before we do the stenting, we do the pre-dilatation using a 3.010 balloon. And this is the result after a pre-dilatation. And then we do the IFUS. So this is the distal part. This is our distal reference. And this is the disease. We can see quite a lot of vulnerable plaque and the disease. And this is around the left main bifurcation. So because there is still a disease and a bit of calcification in the left main, we decided to put the stent across from the left main to the body of the left main. And this is our proximal reference vessel, around 5 millimeter. So we put the stent, DS 3.5 and 30 millimeter. And this is the result after the stenting. And we do a post-dilatation with an NC balloon 3.5, and we do a pot with 5.0 12 millimeter in the left main. And this is the final result after the stenting. And we check another IFUS. This is the most distal part of the stent. This is in the mid, in the disease. This is in the bifurcation and the left main bifurcation. And this is the most proximal part of the stent. Okay, at that time, everything looks good. The patient already quite stable. So we proceed with the routine double antiplatelet. So after that, the patient have no more symptom, but in the third day, suddenly there is a lot of hematemesis. And we check the hemoglobin drop from 16 to 14. And we put a nasogastric tube that time, and we see a fresh blood coming out from that tube. And the bleeding is actually considered spark 2. So before I continue, I should mention that this patient, we already tried to measure the precise DAPT score, and the score is actually quite low. Yeah, the risk for bleeding even up until 12 months is quite low. So that time, what came out in our head is this scale. Yeah, because in this patient, we have to achieve a very good balance because this patient have an active GI tract bleeding. So we have to stop the DAPT to stop the bleeding. But this patient also have just undergone primary PCI in the left main. So if there is a stent thrombosis, it could be hazardous. So at that time, what should we do? We try to switch. We stop the DAPT and we try to switch with a low molecular weight heparin with suboptimal dose subcutaneously. While doing this, we also call the gastroenterologist. That time, we want to perform urgent endoscopy. So, but actually, that time, the gastroenterologist reluctant to do the endoscopy because per their guideline, to do an endoscopy in acute coronary syndrome setting is actually not recommended. Yeah, but we say that we already performed complete revascularization and there is nothing we can do. And after a long discussion, at the end, the gastroenterologist agreed to do the endoscopy, but of course, accompanied by the cardiologist. So this is the result. Yeah, at the gastroesophageal junction, he found a mucosal break more than 5 millimeter. And we can see in the picture here, this is the mucosal break. And in the gastric and duodenal bulb, he found that a lot of bleeding, erosive, hyperemic erythematose, and bleeding almost in every mucose. So that time, the gastroenterologist tried to stop the bleeding by performing a hemostasis, an argon plasma coagulation. I already asked the gastroenterologist, this is almost like ablation, but the catheter does not touch the wall. So after he performed this hemostasis, the next day, there are no more hematemesis. And in the nasogastric tube, there is no blood. And we try to do the test feeding using the liquid food, no residual. So that time, the patient is still on low molecular weight heparin. We still not confident enough to give an antiplatelet. The second day, because there is still no hematemesis, with our finger crossed, we try to give another loading dose of clopidogrel, only clopidogrel. Yeah, and we stop the low molecular weight heparin. Yes. And that day, still no hematemesis, no bleeding, everything is okay. So at the third day, we continue the DAPT with the usual regimen, aspirin and clopidogrel. And the patient still have no hematemesis, no bleeding. And the patient also have no more angina, stable vital sign, no ECG changes, and the hemoglobin is stable around 40. So at the 7th day, the patient discharged with the APT with a good clinical condition. Okay, that is the case for the take-home messages. This scale of balance is very, very important. Like in this patient, I mean, who would have thought about bleeding in this young patient? But it is important for us to always remember this, even in a low-risk patient. And in this case, we always have to try to achieve balance. Like in this patient, we are lucky that this patient only have a bleeding in the gastrointestinal tract. So we could try to give low molecular weight heparin as a bridging therapy while we do the endoscopy. And last and not least, that we always have to remember teamwork. They say that we can do everything as long as there is no complication. But even if there is a complication, then we realize we will need someone else to help. Thank you. That's for my case.
Thank you very much, Andy. That's a fantastic case, and also something that we come across now and again in primary PCI. Total surprise indeed, but really well managed and well saved. So maybe I can invite Joseph to comment on this case and see if there's any questions you want to raise.
Thank you, Paul. That is an interesting case you had, Dr. Andy. You solved the nightmare problems for interventionists, which was bleeding. Since the patients had two problems, mucosal break and also bleeding in every mucus of the gaster, could you tell me how did the argon stop the diffuse bleeding? It's quite interesting for me because in our center we haven't had those kind of procedures. Thank you.
Okay, thank you for the interesting question. So I already discussed with the gastroenterologist. I mean, there is actually quite a lot of technique to stop the bleeding. Yeah, but for this case, he actually at first said that it is quite hard to see the origin of the bleeding because a lot of blood everywhere. Even he already tried to flush a couple of times, but he suspects there is actually quite a lot of bleeding point. So he could use like cryoplasma. There is another technique, but this technique is the safest because this technique, we don't actually touch the bleeding site. And we could actually perform this technique in a couple of places, like in these cases. So I admittedly, I don't know very sure about how this argon plasma works, but the purpose is actually to give a hemostasis. And this is quite I think this is a practical and a good technique in this kind of condition because the results actually quite good.
So what would it be, your long-term strategy for the DAPT? Will you consider to stop the aspirin earlier or probably consider an PPI in these patients?
Yes, for the PPI, actually, after this this event, we already give the PPI. First, an infusion, a drip PPI. But for the DAPT, I think because this is a left main case, yeah, if it's possible, at least we want to continue until 1 year, at least. Yeah, if there is no more bleeding, no more gastrointestinal problem, I think we will try to give DAPT up until 1 year.
Okay, thank you, Dr. Andy.
Maybe I would also like to congratulate Andy because it was not just handling the bleeding, but during the primary PCI, I think one of the main thing that impressed me was the use of IVUS to guide you. The fact that you managed to get such a good results from the primary angioplasty does indeed lessen your thrombotic risk subsequently. I think that's something that I would like to highlight. I still got a couple of minutes, so maybe I would direct this question to Asri. Asri, here Andy used a low molecular heparin as a bridge while the DAPT was discontinued. What's your thought on that? Would you manage it any differently?
It's actually very dicey. I usually don't use low molecular weight heparin. For me, the duration of DAPT stoppage was, I think, 24 to 48 hours, and you know that the antiplatelet action will still linger on for the next, 3 to 5 days and so on. So I think if you look at it, I think the patient has some sort of low-level dual antiplatelet on board. And I think this has been debated before. Now we have IV, Cangrelor and so on, whether it actually works in case of, whether you can use this for this type of patients. I think it's very debatable. I think the most important thing is actually getting the gastro team on board and to scope and to see how severe or how bad is the lesion is. And I think that is the most important thing here. But apart from that, I'm not sure I would actually use low molecular heparin in this type of setting. If I need to stop sometime, I'll just stop. Only worry was the left main was stented. Yeah. Thank you.
Thank you very much, Asri. I think in the interest of time, maybe I'll thank Andy again for a fantastic case, and I'll hand it back to you, Donnie, to introduce our next speaker.
So let me introduce our next speaker. Will be Dr. Tito Purboyo from Mitra Keluarga Gading Serpong Hospital. So Dr. Tito's case will be stent or no stent dilemma in primary PCI. Please, Tito.
Thank you, Dr. Donnie. Good afternoon to all moderator and panelists. Thank you for this opportunity. In this occasion, I want to share with you a simple but very interesting case. As we know that in primary PCI, putting the stent in infarct-related artery has become standard treatment. But in some cases, we are facing a situation in which putting the stent just become a dilemma. So this is the patient, female, 55 years old, presented with typical angina with onset of chest pain 9 hours, and she has hypertension, and vital sign and other physical examination were normal. EKG showed sinusitis with its elevation in V1 to V5 with high troponin T. So this is the coronary angiography. The coronary angiography showed proximal LAD was totally blocked with big thrombus, but the SERP and RCA were normal. This is from caudal view, and this is the RCA. So the first plan was to perform primary PCI in order to restore flow in LAD, but unfortunately in this case, I did not record all of the performance in order to shorten the time. 2 Sion blue guide wires were inserted to LAD and SERC, and then I performed thrombosuction, and after thrombosuction, the flow was still sluggish. And then I do the balloon dilatation in proximal LAD with 2.0 15mm balloon. And then suddenly thrombus was shifted to SERC, and the patient chest pain become worse. So I inserted balloon again to proximal LAD to open the proximal LAD with 2.0 15mm balloon, the same balloon, and give the patient activated intercoronary. And this is the result after the procedure. The flow in LAD was still sluggish, and big thrombus was still there, even though there is some flow to distal LAD. At that time, I was in dilemma to do more procedure or just leave it, to put the stent or not to put the stent or reverse stenting. So if we stent in high thrombus burden, there is some risk of distal embolization. Distal embolization, as we know, occur in 5 to 10% of patients and is associated with bad prognosis. In 17 cases of no reflow, the no reflow phenomenon occurred only after stent implantation, even though the previous TIMI flow was normal. And no reflow phenomenon always has bad prognosis and high mortality. And in the other hand, the deferred stenting also has advantages and disadvantages, and there is no exact time when to do the second procedure. Deferred stenting also debatable. In the first TIMI trial, deferred stenting in primary PCI reduced no reflow and increased myocardial salvage from the MRI. But in larger trial like Danamitri deferred trial, the deferred stenting had no effect on the primary outcome. So based on this finding, the 2017 ESC STEMI guideline, routine deferred stenting was not recommended. So actually, there is some score to predict in which situation the no reflow can occur. And in all prediction score, big thrombus always become important point. So the bigger the thrombus, the risk also bigger. In my case, the thrombus already shift to SERC, and maybe thrombus may also propagate to left main if we do something more in proximal LAD. So the decision was to defer stenting. So the patient was observed in ICU with optimal navigation, and fortunately the patient was stable. She was hospitalized around 5 days, and then echography evaluation was performed in outpatient clinic, and the result was not so bad. There was a hypokinetic in anterior wall, but the ejection was still preserved. So due to National Health Insurance government rule, the next angiography can only be done 4 weeks later. And the result, amazingly, there was no significant stenosis in proximal LAD, and the flow seems good. And I do the IFUS evaluation. This is the evaluation. I makes it faster. So the first patient, there is some fibrotic plaque. Here comes the ostium diagonal one from 9 o'clock. And then this fibrotic plaque with intact intima. There is no calcified nodule, and this is the circ and the intermediate. And then this is the left main. So because there is no significant stenosis, the stent was not implanted. So I think this is Minoka, and I think the thrombus come from a small plaque rupture maybe. Then we cannot see plaque rupture because the plaque rupture already healed because the second procedure was done 4 weeks later, or from plaque erosion. And interestingly, in some cases of the first strategy, in the second procedure, not all of the lesion was stented because angiography showed non-significant stenosis. So this kind of blessing in disguise case. So the conclusion was primary PCI is standard care for treatment of STEMI. However, in case of high-load thrombus, stent placement can lead to thrombocycling, destabilization, and no reflow phenomenon. And the first standing strategy is surgical change in the management of STEMI and has advantages and disadvantages. And in the first standing strategy, second procedure might not always end with stenting. Thank you for your kind attention.
Thank you, Dr. Tito. What a surprise. What a surprise. So from the latest, you left the patient. Looked like the patient still in TME2 flow, but you left it, and then, however, you're right, because there's no need for a stent. Finally. But whether in the same situation, I think 80 or 90% of the interventions will put a stent on the LAD. So Fauzi, what do you think?
It is very nice case. In the first STEMI trial, say that you can defer stent when it's already TME3 flow. Otherwise, it is going to give a problem because the flow is sluggish like that. If you leave the patient like this situation, it's not better than put the stent and embolize. So that's what my thinking is. This is the case of erosion plaque. But the other point is whether the culprit is the diagonal, because it seems to me the very tight stenosis at the diagonal. Whether the culprit at the diagonal and the thrombosis happen at that to the left to the LAD as well. But what you did is the outcome is very, very nice. So no need to put the stent. If I were you at that time, maybe I use thrombosuctions more, and then until TME3 is hopefully it happen. Yeah, if not TME3, and then I don't put the stent as well because this situation, or maybe you have to dilate more. Yeah, that's my point. Yeah. How about the Paul? Maybe Paul as a...
Okay, Paul. So you have another approach, maybe?
I think I agree with what was done. It's always a tough call. I certainly think stenting at that stage would probably end up the stent being occluded. But I would probably, I just saw the way when the last shots, maybe I didn't pay attention, but I just thought it was still TME1, TME2 type of flow. I would probably, as Fauzi said, I will probably try a little bit harder to get back to TME3 flow before I deferred it. And I probably will check the angiogram a little bit earlier because at 4 weeks, or maybe the artery is spontaneously recannulated, but just my opinion.
Okay, great. So this is no right or wrong. So I think Tito already, have some decision, and then it's completely. I think it's all right because finally after 4 weeks, it's completely normal. So, Yusuf, any other thought?
Thank you, Dr. Doni. So what I've been teach while having a fellowship by Dr. Doni is always try to perform a thingy free flow for STEMI. That is why I agree with Dr. Fauzi whenever it is possible for you to perform another aspirating thrombus, and probably I would give the GP2B3 inhibitor upfront before ballooning or aspirating the thrombus. And I would like to know other opinion. Do you have advantages on giving a GP2B3 inhibitor intracoronary instead of IV?
Well,
Yeah.
interesting.
Maybe I can add to that. I use a lot of
Yes, precisely.
GP2A, and most of the trials actually are IV, not intracoronary. So I use exclusively IV GP2B3 inhibitors. And the other thing here is actually using a distal protection device. The Japanese have a dedicated coronary distal protection. We do not have. Parachute and recently a field track by one of the companies, Goodman. Yeah, that's the only comment. But it's a brilliant case. Yeah, brilliant case. Good job.
Okay, good. Yeah, regarding IV and IC, I think it's still debatable. We still need more data. The last journal I read that there's not so much difference. But anyway, I will hand it over again to my co-chairman, Paul Ong, to introduce our latest speaker. Please, Paul.
Oh, thank you very much. Okay, lovely case. So I'm going to ask my good friend Amir to give the last, and probably we left the best to last, right, Amir? So he's going to talk to us about a STEMI case with intracranial hemorrhage, double trouble.
Yes.
Over to you, Amir.
Yes, thank you, Dr. Paul, and all the chairman and panelists. So today I'd like to share about a STEMI case in intracranial hemorrhage. It's definitely double trouble. So I have no potential conflict of interest. So I think stent thrombosis we see lately very rare, since we have a very good stent. We have a very nice also antiplatelet, and also we are using intracoronary imaging more. But I think if it happened, then the mortality is very high. And of course, there is numerous risk factors, like premature cessation of our DAPT is one of the strongest single risk factor. And on the other hand, intracranial hemorrhage is, I think, it's a very nightmare, especially in patient with on antiplatelet, like post PCI patient. And if we see the statistic, it's actually intracranial hemorrhages is very low, especially in low risk patient. So I mean, post patient experience intracoronary hemorrhage, I think the therapy will be problematic, whether you stop or you continue the antiplatelet. So the objective of this patient is managing stent thrombosis and intracranial hemorrhage at the same time. So this is a 59-year-old male with a hypertensive and severe angina for hours prior to admission, with nausea and diaphoresis. And this patient went to a local hospital, diagnosed as non-STEMI, had a PCI on PDA and also the proximal LAD with a 2532. Unfortunately, the stent size 25 for proximal LAD, I don't know whether this is considered this undersized, but we don't know exactly the size of the LAD. So on therapy, of course, the double antiplatelet, and probably because of still the residual thrombus, the cardiologist there decided to continue the enoxaparin. So day 3, the patient had a sudden onset of headache, nausea, and the brain CT showed the bleeding in the cerebellum and also brain infarct. And of course, they withheld the APT and of course the anticoagulant and refer directly the patient to National Brain Center Hospital. And we can appreciate the brain CT there, definitely the bleeding there. And also the day 9 in the National Brain Center, since the drugs was withheld, then the patient again had severe angina with a BP of 60 and prominent SD elevation in anterior region, diagnosed as acute STEMI with cardiogenic shock, with still intracoronary hemorrhage. So the therapy at that time in National Brain Center was decided to again reload the patient with double antiplatelet and of course using the pressor to to stabilize the hemodynamic and refer to our hospital. So this is the condition in our hospital in emergency: severe chest pain, patient still alert with blood pressure is 100, of course, on 2 pressors, with tachycardic and good SpO2, with neurologic examination with slight hemiparesis without any sensory defect. So this is the ECG. You can appreciate ST elevation definitely with RBBB, and the chest X-ray looks, the CTR is still below 50%. The lungs is okay. This is the echo at that time, 54% with hypokinetic in the anterior region with normal valves, unremarkable blood test. And this is the diagnosis is anterior STEMI with 4 hours of onset, intracranial hemorrhage and slight hypokalemia. And this is the angiogram in our hospital. You can see the RCA show the distal part. I think there's still some thrombus there in the PDA, but the TIMI is TIMI 1 or TIMI 2, but definitely the proximal LAD is totally blocked, with also some disease in the mid part of the circ. So the problem is, what is the strategy now? So we decided to balloon the stent, because we can see that the thrombus is in the intra-stent, and since this is proximal LAD, we upsize the patient. We have upsized the stent with a 3.5 NC 15. I think with a high pressure, and you can appreciate that TIMI is restored, whether it's not really a very nice distal runoff. But I think at that time we stopped there, and post POBA, the chest pain alleviate with hemodynamic is improved. We can wean the 2 pressors, and of course we do the full evaluation of this patient, including the resistance analysis showing that within the normal limits, and also we repeat again the CT evaluation, demonstrate stable intracranial hemorrhage. Of course, this patient is under evaluation of neurologist and the neurosurgeon. At that time, we decided to continue the clopidogrel, but we gave the aspirin and the 3rd day, and we gave it at that time alternate day during the hospital, while we see the condition of the neurological as well as the symptom of the angina. So the observation at that time at the CCU is stable hemodynamic without any pressors. Chest pain is much improved with intracranial hemorrhage symptom. I think the neurological is also improved. We do the meeting with the neurologist every few days, and of course we plan for further coronary evaluation probably later, because the patient is quite stable. And I think the follow-up patient discharged after 2 weeks in observation, and plan for the APT 3 to 6 months. If you see with the bleeding, I think the precise depth score is more than 25 definitely, and the plan, I think for this is probably 3 to 6 months. Of course, we also evaluate the neurological symptom, and angina and neurological symptom improve even after 2 months in our hospital. But after that, we don't have any record of this patient, and our colleague in other hospital mentioned about this patient had cardiac arrest and COVID positive a few months later after the last visit in our hospital, and unfortunately the patient passed away after COVID positive. So I think definitely this is a stent thrombosis case, a subacute one, and this is then premature DAPT cessation is strongest risk factor and for stent thrombosis, and many registry showing that intracranial hemorrhage incidence is very low, especially in this young patient. And the management, I think there is no well-supported algorithm. The decision, of course, based on expert opinions, and the principle is very close monitoring of the neurological symptom and early intervention by the neurosurgeon if it is there is expansion of the bleeding. Due to interest of time, I think this is one of the treatment algorithm. And as take-home message, I think there is limited data on management of stent thrombosis, and antiplatelet for this patient is a clinical dilemma, and management currently based on expert opinion, and decision to withhold or continue the APT in this setting largely depends on ischemic versus recurrent prolonged bleeding risk. I think with that, thank you very much.
This is a case being caught between the devil and the deep blue sea, isn't it?
Yeah.
So maybe I will ask Fauzi, any comments on this case? Really tricky case.
Yeah. This is a very challenging case. Very, very difficult one. Whether we have to continue the EPT or to stop it. But what we can learn that the first case, this is the patient got a 2.5 stent, might be this the cause of in-stent thrombosis, in my opinion, because the 2.5 stent in proximal LAD is not a proper stent. But this is the other point is quite diffuse disease, the LAD as well. And then what you did is actually right. You dilate the stent that we're using the 3.5 to have a good expansions. That's good. But the problem that we still have some concern about the risk of thrombosis because of our stent already there. So that's why I think this kind of situation is very difficult. I will consult with the neurologist. Might be I can give one or two dual antiplatelet based on he or she's suggestions.
Thanks. Maybe Yusuf, what would you do if your patient?
Thank you, Dr. Amir, for sharing a very nice case. This is a complications even more terrifying than the GI bleeding. Could you tell us why did you give aspirin alternately? Because I probably would do the same thing, stop all the APT and wait for the neurologist to signal whether we could re-administer the APT. But the alternate aspirin interests me.
Yes, actually for this patient, we have a meeting every few days with the neurologist. Make sure that if we want to give aspirin, that's why we only give aspirin in the third day of this patient. We only give clopidogrel. Even the third day, we give aspirin as alternative. I mean, we ask the neurologist whether we can continue. If he mentioned that the condition is quite stable based on clinically, and also the head CT showing no expansion, then the neurologist mentioned that's okay, you can restart your aspirin. So we restart our aspirin. So it's, I think as outpatient, the patient is slightly headache. I mean, it's improving, but not really 100% relief. But I think we are good to go with double antiplatelet, but I'm not going to plan for 1 year double antiplatelet for this patient. I think 3.6 months based on precise depth.
Thank you, Dr. Amir.
Okay, so I guess all good things come to an end. Okay, so it's been a really nice sessions. So during this time, we have covered, STEMI management in Indonesia. We look at the latest statistics that was presented. We saw a sort of growing adoption of primary PCI in Indonesia, especially when we saw that in Jakarta, where Harapan Kita have sort of really led the field in that. We also look at some of the system being adjusted to accommodate the COVID for STEMI management. Then we learned about the spike helmet sign, which is closely associated with bad outcomes and maybe a warning that we should be a bit more careful in managing this type of MI. And there was some discussion about early adoption of mechanical support. Then we have a case of a primary PCI with patient with GI bleed, and that led to a lot of discussion, and also, the mentioning about, intravascular imaging guidance and the early engagement with the gastroenterologist. Then we have a case of poor flow, and then we talk about whether to stent or not to stent. The time that Tito also shared with us the benefit of deferring some of these cases, and indeed up to 15% of the cases after deferment actually does not require stenting. And of course, the final case, we left the best till last, which is the case of primary PCI with intracranial hemorrhage. And that obviously generates quite a lot of debates. So for that, I'd like to thank all our panelists and lecturers for sharing these sessions. My co-chair, Donnie Furman, of course, for officiating these sessions. Isic for the kind invitation. And I hope that you all get to enjoy the rest of TCTAP 2022. For that, thank you very much for joining us. Goodbye.
Goodbye. Thank you.
Bye.